I'd like to introduce Dr. Patricia Segura, who works at the National Institute of Respiratory Diseases. She's going to be talking about the risk index for vulnerable populations. Thank you so much. First of all, I would like to thank Beatriz and WRI for the invitation to present in this forum. It's a pleasure for me to be here with you all. I think that measuring and determining the quality of the air is really important. Mitigating pollutants is also significantly important. But determining the effects that pollutants have on human health and on the health of all living beings, that is what I'm in charge of studying. And I think that if we don't notify the population about the quality of the air they're breathing, then probably we are infringing one of the most important human rights that everybody has, which is access to healthy air. I think it's important to remember that in 1990, Mexico City was considered the most polluted city in the planet by the World Health Organization. Thanks to the efforts of many decision makers, by the government, by the population, by the civil society, by the private industry, by a lot of people, today Mexico City is probably one of the mega cities with the best air quality, despite being a big center of public transit. And something important we have had for years now in Mexico City, for those of us who live here, is air quality information. In medicine, one of the phenomenon that we study a lot in order to understand diseases and their development is what we call exposome. What does exposome mean? It means the process in which biology, our cells, meet the chemistry. From the moment of conception, our mother is in contact with chemical substances, and until we die, we're going to be interacting with chemical substances that we receive, voluntarily in everything we eat, what we smoke, what we drink, but also involuntarily. Breathing pollutants is a huge source of exposure to chemicals since we are in the womb. This can trigger genetic changes in the expression of proteins, how we get sick, and the bacteria that are part of our body, the microbiome. It's going to determine the composition of our immune system, how we'll be able to defend from different aggressors, and this is going to be going on for our whole lives. So today we know that there are sick people and not diseases. Everybody may be in contact, for example, with the COVID virus, but everybody reacts differently because everybody has a different exposome. Therefore, the World Health Organization for many years has been saying that the main risk for 99% of the population of the planet is exposure to environmental pollutants. And depending on the nature of the pollutant, these may trigger different kinds of cardiovascular diseases, metabolic diseases, mental diseases, delayed development. So it's hugely important to understand what's going on with the exposure of these pollutants throughout our lives. As I said, there are acute effects. So if I go out right now and there's an important spike in ozone, I'll show a series of symptoms like a headache, irritation to my eyes, discomfort in my nose, things like that. But if I'm exposed to ozone every day of my life, I may generate tolerance. But I'm also going to generate chronic processes like metabolic diseases, chronic respiratory diseases, etc. So now we understand that we need to study everything that these pollutants are doing throughout our lives. But there are some pollutants more susceptible than others. And there's a lot of things that affect how susceptible they are. Age is extremely important. Life extremes, newborns, babies, toddlers, seniors, people who are pregnant, because of their age and condition, they're going to be a lot more susceptible. But what about other conditions? Conditions that are not going to change over time, like having a chronic illness, like maybe having diabetes, metabolic illnesses, cardiovascular diseases, asthma, COPD. People with these diseases are going to be a lot more susceptible than the rest of the population. There's also healthy people and sick people who are overexposed. What do I mean by these? People who spend more than 2, 3, 4, 6, or even 12 hours outside because their job, or because they have to commute, riding a bicycle, or walking. They spend a lot of time outdoors. And of course, workers that are exposed to chemical substances through their jobs, and they are also exposed to the environment. So these people, which we call susceptible because they have a greater proclivity to developing illnesses due to exposure to chemicals in the environment, they may develop, as I mentioned before, acute effects, rhinitis, conjunctivitis, sinusitis, different kinds of inflammation, secretions, but also medium and long-term illnesses like respiratory or digestive system infections. And even chronic diseases, as we know, PM2.5 is now considered to be a type 1 risk for cancer, just like smoking. It's the same as being exposed to these chemicals, so we really need to be aware of these situations. These risks are not just respiratory diseases. There's dermatological issues, mental health, microplastics associated with disruptions of the endocrine system that can interfere with pregnancy and can cause premature births. So now we also have an obligation to determine air quality so that we can provide the population with health. Another thing that is hugely important is that our respiratory system is not selective. When we breathe, we don't decide to just breathe in ozone or particulate matter or microplastics. No, we breathe in everything altogether, and these microparticles that are combined, as we can see on screen, with a center of organic carbon, inorganic carbon, formals, volatile organic compounds, air particles, microbiological agents, bacteria, virus, as we saw with SARS-CoV-2, they will come in contact with our immune system and they will start creating illnesses, precisely because these combinations, and most of the air quality indexes do not take into account these combinations. This is why we must understand what effects these combinations of pollutants cause to our health. The study that we recently carried out with animals in a laboratory, we had animals breathe in air from Mexico City together with an allergen to make them allergic. What we noticed is that PM 2.5 in Mexico City triggers allergies. It wakes up the immune system and it makes us allergic to things that we normally are not allergic to. We also observed that depending on the type of pollutant being breathed, the immune response may vary. So some responses are inflammatory, others will be much more aggressive and can lead to chronic illnesses like fibrosis, cancer, etc. So it's very important to determine the composition of mixtures and determine the time of exposure and susceptibility in the case there is also an existing condition. So the objective of our work, which was undertaken by the Secretary of the Environment, the Directorate of Air Quality of Mexico City, when Beatriz Cardenas was in charge of this department, this was her initiative, to generate this air quality index for susceptible people, a risk index. The idea was to get this susceptibility by morbidity. This is incredibly important because most air quality indexes are based on mortality. And when you're dead, you're dead. When someone is dead, well, they're dead and there's no difference. But the importance of this index is that it's based on morbidity. This is to say how many morbidities or how many acute morbidities we have due to spikes in pollutants or mixes of pollutants. This makes it a bit more complicated because sometimes it may be ambiguous. When somebody says they have a headache, more or less discomfort, so this index was based on acute responses, especially the number of cases received by health services in Mexico City associated with air quality. So over 6 years, we measured cases coming into the emergency room because of acute respiratory responses. We took out all the data about air quality from 2010 to 2015, and we built a model that includes multiple pollutants to understand the risk of each pollutant in terms of their levels and their combinations, and how they affected these health emergencies. So over this period, the Secretary of the Environment analyzed air quality with pollutants that normally have spikes that go over the recommended norms from the World Health Organization in Mexico City. It analyzed weather conditions, and we also got the results of 40 health facilities in Mexico City, where the initial diagnoses were acute respiratory illnesses like acute infections, asthma, chronic obstructive pulmonary diseases, pneumonia, bronchitis, and some other respiratory pathologies that can become more acute. We recorded it by age groups in the compounds with emergency room visits, and therefore have a relationship of the risk of each pollutant and their combinations for vulnerable people. And under this period, we got almost 611,000 visits to the emergency room in 280 days, approximately during those 6 years. And it was important to see that at least 40% of these pollutants, these visits, were associated with spikes and combinations of pollutants 1 to 3 days before they were admitted to emergency rooms. It's important we understand that Mexico City has 32 monitors, 13 that were close to hospital centers. Most of the population in Mexico City takes medical attention close to where they live, an important fact to consider. And then we developed some algorithms to determine the risk or the weight of each pollutant in terms of increasing the risk of acute asthma, COPD, etc. And we got a formula that allowed us to calculate the risk index for susceptible people. And we noticed that there were 3 pollutants that were directly associated with these emergency visits: O3, PM 2.5, and NO2. This last one probably because over these years, this was the main precursor of O3. So based on a final constant, we managed to reach a scale from 0 to 10 to determine the combination of these three pollutants and to see the risk for the population that were exposed. So the advantage of this risk factor of this index is that it combines a lot of different pollutants that are usually present in bad air quality spikes. It's a forecast because it tells us what the air quality is going to be on the next day. It's measurable during the day. The measurements are taken. And there's a correction over 3 days. As we saw in the presentations, there might have been a spike, and the patient was admitted with an acute asthma response. Not immediately, but the following day probably. This can help us detect spikes in the days after. What we are looking for is to individualize it, so that everybody knows how sensitive they are to the pollutants, and of course, based on morbidity. Now, based on these combinations, we created a series of matrices to determine indicators, where indexes can tell us on a scale from 1 to 10, or even over 10 in some cases, where 1, 2, 3 means none of the three pollutants exceeds the level of concentration recommended by the WHO. In this case, we have pretty good air quality. Even susceptible people may not even show a response to these low concentrations. Then 4, 5, and 6 indicate that at least one of the pollutants has gone over WHO norms, but it's still not over Mexico City norms. Then 7, 8, 9, and 10 show bad air quality. Some of the 3 or all 3 could be above standards of Mexico City. And at 8, an environmental contingency could be declared in the city. In May 2019, we surpassed 14 because there was a circumstance in which there were a lot of wildfires. There was low meteorological pressure, and the middle of the country accumulated high levels of ozone, PM10, PM2.5. We were actually in the middle of the study that we validated with patients, and we were able to tell the patients to not go outdoors. It didn't matter if we stopped the study, but ethically, it was truly important to let them know that the environmental conditions were not adequate. So what the Institute did was validate if this risk index for susceptible people could effectively predict potential worsening in patients. Therefore, we worked with 3 groups of asthma patients: children with asthma, adults with asthma, and patients with obstructive chronic disease. And they were asked to participate by verifying and answering a series of surveys. So these surveys are as such validated or verified by the board and GINA, which are the 2 board associations for asthma and buck care. Patients would fill out the survey every night after having spent at least half an hour outside in Mexico City going over the symptoms. The symptoms asked about irritation of the nose, throat, eyes, skin irritation, and specific characteristic of the illness, like bronchitis, asthma, etc. We were originally looking to have at least 150 patients for each sector, but unfortunately we had to stop the study in February 2020 because our hospitals became the national COVID center in the country. So we were unable to continue working with the patients because they weren't able to go outside, so we had to halt that. These are the validated surveys by ACT, Asthma Test Control, and CAP, Control Assessment Test, for asthma and COPD in both cases. And these were the questions that kids would answer every night, along with the parents, or also adults would answer about the symptoms they were presenting whenever they went outdoors. This is correlated with the risk index for susceptible people. We were only able to have 126 patients. The least portion we had were COPD because they're older patients who did not go outside that much. It's also worth noting that of these diseases, asthma is a lot more common in women than men. Almost all COPD patients were men. Then it is also important to consider the age ranges. The age range for children was between the ages of 5 to 15. And it's also worth knowing that all patients were diagnosed by pulmonologists and specialists from our institution. It's also important to mention that they had no limits. They could fill out the surveys every single day. Children were actually pretty thorough in filling the survey because they had a little birdie there that would die if they didn't. Unfortunately, we lost several records. However, we decided to take patients who had at least 10 records that we could correlate with the risk index along with their symptoms so that we could make an appropriate correlation of how sensitive they were to pollutants. Now, to assess the correlation between the symptoms and the air quality through the risk index, we had ROC curves where if we had at least 95% of trusted interval and it was greater than 0.5, then we would consider a correlation, positive or negative, symptom versus the air quality. If we look at these results per study group, at the top we have adults with asthma, then we have children with asthma, and at the bottom, adults with COPD. And seeing these people, we were able to see that these symptoms amongst adults are directly correlated to eye irritation, throat irritation, and having a dry nose with difficulty breathing. All of these patients, many of them are allergic and presented skin irritation, which was directly correlated with poor air quality. So the worse the air quality, the more symptoms. Children are less sensitive. Almost did not present acute symptoms. The greatest correlation was eye irritation, dry throat, and dry nose, as well as chest pain. And in the case of people with COPD, they mainly presented throat irritation or nasal secretion, cough, which is also very important. And lastly, if it was not nasal secretion, having dry nostrils. Now, in the next chart here, we can see that this is the amount of symptoms associated. I mean, there were patients who would tell us they would present all symptoms. This patient said he had all symptoms, while there were other patients who didn't present any symptoms, around 40% of them. It is also worth noting that we didn't ask for any acute or controlled patients. This was a totally random sample, so that all patients that have symptoms have bronchial hyperreactivity who can respond at any time. So here we notice that 40% did not respond or did not present any of the symptoms. We have a large part of the population that does present 2 or up to 3 symptoms. As I mentioned, cough is the most common symptom related to bad air quality. Dry noses, dry throats, a lot of irritation and irritated eyes, difficulty to breathe, headache, wheezing for some people with asthma and COPD, and eye irritation, and chest tightness is hardly ever presented. It's also worth noting that the worse the air quality, the higher intensity in the symptoms, because we would also ask about the intensity. So the worse the air quality was, the more intense were the symptoms, according to patients. And also relatively low concentrations for lower symptoms. But in a very low air quality, you have less symptoms, but they are a lot more intense, such as cough. This is very important to keep in mind. Another thing worth noting is that we relied on vulnerable patients. The risk in which people were susceptible to this is indeed a good predictive indicator of potential spikes in these patients, low potential risks to these patients. And actually, since November 2017, the CDM posts every day the risk index for susceptible people, and the entire population can access it and pick their number. How sensitive are you? On which number do you begin to present your symptoms, so that you can make your own decisions? COVID contingency stopped all of us, but for example, this index helps us understand if I were to find out I'm a number 7 and today the level is a 7, we can decide to work out indoors, which is part of what we're looking to do here. And I think it doesn't make sense here to generate all of these tools if we don't intend to empower the population, provide the population with know how they can make decisions based on air quality. This is why we are now generating our own app, so that it can be accessed by the population every day. The app is called AURA, which stands for Urban Application of Air Risks in Spanish. And its benefits compared against other air quality indexes is that it forecasts. It's individualized because each individual will have a different number, even at different times throughout their lifetime. COVID and influenza create bronchial hyperactivity. So if any of you came down with COVID and experienced a long presenting cough or have another respiratory infections, it is just because of these viruses leave us more sensitive, and that's going to pass after 3 months, 6 months, etc. But it's important to know that in these periods where you can be more sensitive, maybe your number, instead of being 7, it starts to show responses from 4. It is worth mentioning that asthma patients, almost all of them began responding on 4, which to us is below the maximum amount of air quality in Mexico. This application will give the value by number and according to colors, displaying a clean or a dirty sky. It also explains the risk index for people who are susceptible. And while we do not have it in Mexico City within an app, it's polemic calendar, even with RIMA, which is the Aerobiology Mexican Network in Mexico, managed by the Atmosphere and Climate Change Institute at the UNAM. They will be reporting in the app weekly the main pollen present in the environment along with an image. Because scientists, we like to run skin tests and then tell you, okay, you're allergic to fruxinus. And there we go, we have the image. You will see the tree, which is like the one just outside this room. And if I'm allergic, I will simply wear a face mask because the purpose of this app is to provide you with methods to prevent exposure. If there is no exposure, there will be no harm. So what we need is to empower individuals to let them know, okay, if you're going to step outside, just wear a mask and you'll be good. It's not a virus issue. It's the pollen. If you happen to be allergic. And I think that's very important. We already get notified UV radiation levels, but it is very important to inform the population about the risks of it. Last week, we had the cooler temperature wave that lasted 3 weeks, and the UV radiation levels were over 16, when the maximum level should be at 4, the highest, without appropriate protection. So it is very important that, of course, it's great to improve the air quality, but if you have less particles, radiation passes through a lot easier. So there's less particle materials, but more radiation. And we have to take care of ourselves, wear a hat, sunscreen, long sleeves, etc. We need to educate the population. And the idea behind this is to have customized or personalized. If people want to sign up, they will have to share if they have already diagnosed diseases, metabolic diseases, etc. They are given an initial survey so that we can place them in their sensibility level. And after 10 measurements, where people can say which symptoms they presented, the application, the algorithm, will be able to determine what your number is in such a way that if an individual decides to do so, they can receive a message based on that number to let them know tomorrow will be a 7 or 8. Take your precautions, like maybe work out after a certain time, after the pollutant levels have dropped, just to let you know that this is under construction. We hope to be able to provide the service for the general population in their app or the Aura app. And the risk index that is now validated with susceptible patients in Mexico City will also be included, because at the end of the day, providing good air quality is everybody's job. But being able to provide information for the population so that they can take care of themselves and they can auto-detect in an interactive way so that they can let us know what their symptoms are so that we can then know what the true susceptibility of our population is. A lot of people are chronically no longer responding in an acute way, but they begin to present asthma, cancer, etc. So we want to avoid chronic exposure and detect it starting from the acute exposure. So here's my contact information. I would like to thank all of the authorities, everybody who has worked on this, my students from the Technological Institute of Monterrey, who have been working closely with the patients, and of course, Betty Cardenas, Monica, Olivia, who have trusted on our work, and after many years, the index is now validated. The paper is about to be sent out. The images I shared today are from the paper. If you have any questions or comments, I am at your service. And of course, also to Mari Carmen Calderon, the director of REMA. Thank you.
Excellent presentation, Dr. Patricia. We will move on to a round of questions.
At an individual level, when the clinician in the clinical room is interacting with a patient who has presented with symptoms, have you developed something for them? Are there like communication messages specific to air pollution control that should be passed on to the mother or this senior citizen? And then the other one is, we have thought about such an idea back at home in the city, but we have a challenge where we are affected by the dormitory effect. You have so many people coming to the city to earn a living or for treatment. I have seen that you excluded quite a number because they are not coming from Mexico City. The air quality monitors are at hospitals, but this is not where the patients stay. The patients stay somewhere where the exposure, possibly the longest exposure happens, maybe at home or at school or in another setting where they come to the hospital for treatment. I don't know the waiting time for Mexican hospitals, but maybe it's short, relatively short. So you wouldn't think that most of the exposure happened at the hospital. Maybe it happened somewhere else.
Yes.
But we are matching exposure of the air quality measured at the hospital and matching it to a patient who has come from somewhere else to this hospital for treatment. So did you put that in consideration? That has been my main puzzle. You want to do that, but then you realize that this air quality level here is not the one I'm exposed to because I don't live here. Thank you.
In fact, you're right. For example, in respect to the risk index, it's for the entire city. In fact, it's an average of the quality of all the city. And as well as you said, we have a lot of different micro ambience for different parts of the city. And this is real. But this is a first approach, and we found correlation, even when we have different exposures. In fact, for me, the real challenge is exposure, because it's not the same thing to stay. I mean, I can see from here people who works on the street, and they stay from all the sources, I mean, all the cars and everything, many hours, and they are very, very exposed. But contrary, for example, indoor, we can have other pollutants, and we cannot distinguish between these two. But in the case of the questionnaires, we used to ask about that. If we are exposed to other smokes, or, for example, tobacco, marijuana, or whatever, or maybe in the work, the possible exposition to other ones. So the idea in this case is just to have at least half hour outside, at least, but all the time we're taking in account the time of the exposure outside, no? So it's important to try to have both. Of course, the real challenge is maybe have a little monitoring side of every people, but this is almost impossible. I mean, there are many studies, but for me, the idea is to have a tool for the entire population. I mean, in order to have much more clarity for everyone. And of course, and this is for Monica, the idea is to have this index for all the, at least for all the monitoring centers, maybe 12 or 32, whatever you want. They are working on that. And the idea is to have the number for the place where you pass the more part of the time outside. For example, maybe you live in Iztapalapa, but you work in Coyoacán and you are outside in reality during the travel from one alcalde to the other one. I mean, that's part of the idea.
For example, these atypical environmental events like fires or eruptions, how can they be reflected? How does that variable also influence the index? Well, the index we forecast, it comes out in the morning, but we run other machine learning methods during the day where we adjust already with observed data this index. So for example, the fires, maybe the model doesn't see them, but the observed data does. Then we make the adjustment and change the value. That's it. In the morning it comes out, and in the afternoon we update with observed values. So this allows that when there are contingencies, as ozone starts to rise in the morning and PM as well, then let's suppose that in the morning we can say it is 5, but with observed data we are already seeing and it goes up to 7. And of course, we have machine learning methods that are doing it with past data. Okay, thank you so much. Okay, this is a strange transition. I apologize to my colleagues in Bogota who work specifically on health issues. But there's an experience that we had, and I don't know if it can happen here. That is, that having two skills to say the same thing is confusing, isn't it? You know, usually air quality reports are not sent in micrograms, but the air quality index is sent, either from the United States or one of our own. In Bogota, we have one that is more or less similar to that one of the United States, with different cutoffs. But what we realized is that when we have two different color palettes, people get confused. So I know that there's an issue of like training or teaching, but still, let's say that what we find in the end is, in both cases, they are linear relationships. And what is being taken out, what the secretary is working right now, is to avoid having two color palettes. The index is of air quality and health risk, both at the same time. Obviously, this index has its codes also from the health organization. That's it. Behind the development of these codes, there are epidemiological studies in Bogota. So let's say that what they have found with the feeds that they have is that it's better to manage a scale for everything. And in the same temporality, that also that index is going to migrate to what is NOCAS. Then let's say that gives a much faster response time. That's kind of the observation. We can go deeper according to that. I completely agree with you. And I will tell you that it not only has that complication for the user, but also the legal and political complications for several reasons. For example, a while ago, I was commenting on the mechas that no longer exist, but the population in Mexico City already knew about it. So when you use it to say 100 IMECAS, 150 IMECAS, contingency, and people already knew that they stopped circulation and that the children didn't go out for recreation, and now they removed the last name IMECAS and already say 100, 150, but you don't know what. It is the index that is governed by the air, and that's it. Let me tell you that now we are working with the air application of Mexico City, also with the intention of putting many of these. This one that is individualized, that has a specific message for the population. Well, I will tell you that this index, rather than being the correlation of health and air quality, is the susceptibility of the person. So what is reflecting, what it will reflect is you, Edison, how sensitive you are compared to Monica. And she's going to have one number and you are going to have another number, whatever you want. Maybe you smoke, I'm making you up. But if you smoke, you are already more sensitive, or the other way around. You can stand more. So that's why they put different colors and numbers so you don't get involved. They don't go to 100, whatever you want. But everyone has a number. Everyone identifies their own number. And I have, as I was telling you, among the patients, children that were 4 and children that were 10. Why? I don't know if they didn't come out more, etc. Now, you're absolutely right. What we do have to do is to make that communication to the population as clear as possible. I believe that this, rather than getting into the National Air Quality Index, which is single pollutant, because this is very important, is one of the big differences with our index. Here the combination is taken into account, something that's not done. For example, just when we were talking about this crisis for COVID, we didn't reach 150 ozone. So the contingency was not lifted, but there was a lot of particulate matter, PM10, PM2.5, which at that time were not criteria for contingency. Until suddenly, the one that tells me, wait, we have a lot of this, we have a lot of that, and a lot of other. Yes, we have to stop people. Then they had to change the protocols to say, when there are several high pollutants, which is not common because Monica also talked that it's not so common to have such continuous peaks of the tree, unless there are conditions like the volcano or the leak or whatever, or fire, which are eventualities. But what is certain is that all the pollutants are there in lower or higher concentration, but they are there in the air. So I think that what we have to do is start looking for tools that we can see that the population is understanding. Because one thing is that all the specialists sit down to make our standards and quality indexes, and I understand it perfectly. And without the forecast and this and that, but it's very important to ask the person. With air, we have a lot of microambients, the quality application of Mexico City, and we are also improving to make a better rights communication with the population. And we made a series of workshops with educational personnel, in general with health personnel, and with the general population about messages, how they understood them, iconography, etc. So we are trying to see what is a more appropriate message so that everybody can understand it and everybody can interpret it in the right way. Because it is one thing what you have to say legally, the PM, the micrograms per cubic meter, the ppb or whatever. But it is another thing what the population have to interpret and understand to take care of itself. That's really what is important. So you're absolutely right. I agree with you. It's only one message that must be given but it's a message that must be understood not only for the population, but also individually. In other words, when I protect the most sensitive, I'm protecting everyone else, but I cannot restrict everyone. In other words, if I say right now, they are, I don't know, 80 ozone levels, a sensitive person could already have every symptoms, and I'm not going to stop the whole population because he's a sensitive person. On the other hand, if I tell him, hey, you're number 4, there are 4 outside, but it's you, and give you recommendations for you, just as there will be contingencies for all the people. Yes, I understand. The new index is under construction, so it's accompanied by differentiated measures. Let's say that for people who are sensitive, they don't put it as numbers, but specifically to the condition. I think that is the way they are individualizing it, but I don't know the specific details of the communication part, but well. Also, the other question is Bogota has the advantage that ozone and nitrogen are extremely low, so that's why we are looking for. We are planning to do that multi-criteria analysis with ozone, but let's say that science we have to get that no gas with particulate material mainly. This study that we are going to call EVOCA 4.0 will be done in 2 or 3 years while we collect enough information for the new study with ozone. Perfect. The new index already uses the no-cast, indeed.
I'm Rahma from Jakarta.
Thank
Thank you so much for your information. I just wondering, is there any national index? And then does the research carried need to tighten the national index, or is it because the pollution in Mexico City is getting more polluted?
This is this index is just for Mexico City and megalopolis. I mean the part of the suburbs, but it's just for Mexico City. And this is because nationally it's pollutant by pollutant, no the combination. But we are ruled for the national index or air quality. But this index is just a supplementation, is supplementary for the information for Mexico City, because it's the combination of 3 pollutants.
Oh, okay. Because in our national level also we have the index, yeah. And then we until now I think we don't know how they make the index, the formula to get the index, how to do. I think there are no research something like this that several years for get the index. So in this case, I think make the idea that because of the Jakarta, it's getting more polluted. So I think it's we have to do that. Maybe we have to make what is to make a little bit tight than index level. Thank you very much.
Thanks to you.
Thank you very much for this presentation. It was very eye-opening towards what would make sense to the population. I'm no expert at this, so I am just throwing this out there to you, to the City of Mexico and Bogota, because you have run ahead of us in many things. But in Africa, we find that a lot of data that is being dispensed out there about the state of air quality, even the forecast that we want to give to cities, would not really be impactful as, you know, telling people that, oh, this is unhealthy, hazardous, or whatever. So according to your experience and the experience of Monica and Edison, what would you advise that Africa, cities in Africa who want to develop local air quality indexes, locally relevant indexes, what is the optimal path to take, and what are some of the mistakes that we should avoid? Well, having that, so that when we communicate this message, and Alex, you'll agree with me when I say it will never make sense when we communicate numbers.
Yes.
Yeah. So what is the optimal path according to your experience? So it's out there to all of you.
I'm going to start with my part, that is health in people. And I think that the first time is to have records about the effects of these pollutants. And for example, when we have these peaks of pollutants for any question, to have that information of health, have all the records about visits to ER rooms, to urgent rooms, or for people who has different diseases, and have that records in order to compare with the quality of the air. And the first thing is measure in a good quality of measure of the quality of the air, have of the inventories, and have the records of health, and after made the association. But as well as we perfectly know, every part of the world, the main part of the people used to base on OMS guidelines or EPA guidelines. But every place all over the world has their own conditions. So you need to have your own conditions. And based on that, create your own air quality health index, because it's your reality. And that's the only thing that I can say.
Because yesterday we have been talking, Patty, the first day, the representatives from the cities and from the states and from Kenya also share with us what are the challenges, what are the needs, what are the levels.
Okay.
And something that we talk about, and I think we forgot to to keep talking about it, is that in the global south, cities are still experiencing problems with PM10. Mexico City not. And we forget, but Guadalajara, Monterrey,
Yes.
León, and the
That's
rest of the, not only in Mexico, but outside of Mexico and the global south, we do have the problem of PM10. Hasn't been solved. And usually our
Yes.
colleagues from the global north, they don't even talk about it. It's actually not anymore in the standards. So, and I think in terms of health, I remember having this discussion many years ago with my colleague from, that he was a physician. He was telling me, why you guys are just so only talking about PM 2.5. We do have PM10, and he was talking about all the rest. The how you exacerbate the condition. So that's an issue that talking about the conditions. Yes, we are worried about ozone. We are worried about NO2. We are worried about PM 2.5. In addition, PM10.
Yes,
it's just like that's the other issue.
Right now, the health and air index is being updated because this was done under current norms. These norms were previous norms, but they've been updated. Therefore, the index needs to be updated as well in accordance with the updated norms. But there's a big discussion about how the intervals are calculated. And one thing that our general director has said is that the intervals need to be done according to the health risks, but they need to be unified. That is, if the health risk is, say, 2.5, whatever, for SO2, the 0.5 value needs to be just like the value for 2.5 for PM10 or PM2.5 or ozone. Because if you're talking about poor air quality or very poor air quality, the risk for all the pollutants is the same for health. And what a lot of the indexes do is that they fail to consider the mortality index or the risk of respiratory diseases. So the suggestion of our director is to change the intervals according to the health risks. And for this, let's go global studies or global metadata. You could also use this information because our countries, for those response, you really need years of study. So this is what's being done here. This is Mexico City's proposal to change it in accordance with the health risks.
That is right now under discussion. And we'll see what turns out of this, because right now we're looking at it legally, whether the changes are going to be approved as we propose them. But I do think that the index should be done so that everybody has the same risk within the given intervals. Because the value of when it's poor air quality, when people start being affected, we base that on old WHO guidelines because they changed them when we had already updated our models. So what we did is that the value of good was put as a limit according to WHO guidelines, and for bad are yours, which is the old WHO guidelines. Now, the WHO has some intermediate objectives, and they suggest as a country, depending on your economic, social development, health of your population, that you should determine the value of the standard based on the conditions on your country, economic, social, and health conditions.
Here, we're starting from the fact that both and Mexico City have information to conduct their own studies, their own epidemiological studies, that is. But the idea is to start from zero, for lack of a better word. Bogota, many years ago, perhaps 15, 20 years ago, was beginning to gather information from countries, and they said, okay, let's assume our population behaves the same as this niche in the US or this niche in Mexico. They were trying to find common ground or similarities in terms of culture or economies. And based on that, they began conducting the first analysis of this health risks. The important message, and the reason for which air quality became important in Colombia over the last few years, is that one thing is to say to politicians, hey, we have poor air quality. And another thing is to tell them, hey, people are falling ill due to the air quality management. A lot of people are dying. And we go beyond this. This represents a cost to the city. So maybe switching the mindset and adapting it to what politicians can actually see. So how much cost does it imply to assist or keep people healthy? So when they began conducting these studies, I think back in 2008, that's where Bogota began developing their contamination plan. And in this kind of analysis that were conducted at first with information gathered from studies mainly from the US, was what triggered this research and management topics to fight pollution. If I'm not wrong, I think there were a lot of old studies that had a relationship with PM10 while it began fading away from the standards. But these old responses, I'm sure, are still kept on record somewhere. So yeah, that would be my recommendation.
Thank you very much for your presentation, Dr. Patricia. Thank you for joining us today.